Если нужны его слайды, то можем выводить слайды спикера на экран. Есть слайды у спикера? Нету? Israel, do you have slides?
Yes. If you
Can
want,
you
I can share my screen.
Yes, can you please kindly share your screen and we can start. The interpreter is there for you.
Yes, thank you so much. If the interpreter is ready, I will start.
Interpreter is ready. You.
Emergency medical systems and clinical management specialist here in Kiev country office. And with me is also our national clinical management consultant, Dr. Yuri Zihariev. So I want to talk to you this afternoon already, about the clinical management of COVID, especially when it comes to emergency medical services. Just 1 second. So yesterday we started a series of webinars regarding clinical management on COVID-19. These are nationwide exposed, so everybody can actually reach these webinars. They will be happening every Wednesday at 2 p.m. on a Facebook platform. So hopefully all of you will get the advertisement of next week if you didn't get the one yesterday. Anyway, they are all recorded, so you could actually reach the knowledge anytime you want. So what we are looking for from WHO is to actually give all the professionals, from the fetchers in the ambulance that actually go and get the patient, to the people on the dispatching centers that are actually getting the calls, to the doctors and nurses receiving the patients in the hospitals, and those who will take care of them either in the wards or later on in the ICU units. What we want is to actually unify all the medical criteria for the clinical management, so that we all understand why we do several procedures and why we react in several ways. And this is because of a pandemic. The system is not ready to actually absorb the enormous number of patients that we are having. So we actually need an algorithm to do the optimal use of our resources: emergency medical system, ambulances, and beds in the hospital. So just a brief reminder, we all know that COVID-19 is a respiratory tract infection that was later on. We have not tackled the situation in the world, fortunately, and today we have been discussing the vaccine has come to our lives, and we fully encourage people to have it, especially not only population, but to us, healthcare workers, which are fully exposed. As you described earlier, the vaccines are safe. Of course, there are side effects that are being described, but the benefits are always, to this day, much, much higher to not getting it. The transmission, we already know that the transmission between humans is through respiratory droplets and contact and vomits. It is very important that we encourage the measures of social distancing and the use of masks in society to actually stop the transmission. Even though sometimes hospitals become a source of transmission because the sick people are in the hospital, and in the very beginning of the pandemic, we didn't have good access to PPE, it is in society where we need to actually stop transmission. And that is through the social measures, distancing, and the use of masks. We all know that this is an acute respiratory infection, and fortunately, most of it will happen in a mild or moderate form, meaning the moderate forms of COVID won't need to have any hospital admissions. Yes, we will have a call and we will have a visit with our ambulance to some people, and we will make a clear diagnosis of COVID because of the epidemiology criteria, because of the clinical criteria. But we have to understand that whenever the moderate cases can be isolated and treated home, that is the best way, so that we stop putting that much pressure in the hospital system. Let's remember that the highest mortality happens in the elderly, meaning if our patients are over 60 years of age, and that has happened in countries like France, Spain, and Italy, where actually this elderly segment of population is very, very high, they have been the ones reporting the highest level of mortality. That's why in the vaccination campaign, they are the ones receiving the vaccines first. However, until the vaccination coverage is spread all over the population, these are the segment of population that we need to take care of more sensitively, not only elderly, but also people with risk factors. The prevention, as we said, is the respiratory hygiene, the proper hand washing. We never have to forget that. WHO is doing an enormous work regarding prevention and control measures in order to actually stop transmission, starting with hand washing. So that is something that at our all levels, in the ambulance, in the hospitals, we need to have hand washing points. In our ambulance, we have to have access to any sort of hygiene for our hands that can be any of the gels that are available in the market in order to actually have this hand sanitation. In the healthcare settings, the IPC measures are requiring the triage levels and the treatment levels. And as we can see, when there are situations where we will generate aerosols, we need a higher level of protection. When it comes to treatment, we already have vaccines that we have to use. And we know that the treatment is the supportive care delivery, meaning there is not a specific type of treatment, but we need to do symptomatic treatment, always counting on the supplemental oxygen therapy, which is required by nearly up to 20% of infections. These are the number of people that will develop a severe disease. And I go back to what we said before. If we don't stop transmission in the community, we will have a higher number of severe disease. So we have to count on protective measures in the society in order to actually have a decrease of cases and pressure in our hospitals. The early recognition of those or at risk of severe disease and access to critical care is the key. We need to know how to identify those who are going through severe disease or who will actually be exposed to develop a severe disease. Let's go to the next. So what we have to do is screening and triage. We need to do screening at all points of access to the health system, including the primary health centers, the clinic, the hospitals, and community settings. At these very points, we need to apply the appropriate infection prevention and control precautions at the triage to prevent the spread of illness to us, the healthcare workers, or other patients. We cannot afford any more doctors and any more nurses to actually be exposed, and that is to simply following the prevention and control precautions through our PPE. To do the triage, we need to use a validated acuity-based triage tool to prioritize the patients that need immediate care. And this is important because we may face one night in our shift that we have 30, 40, 50 people at the very same moment in our unit. We need to know how to prioritize who needs attention first, because that will make the difference in order to actually what we do, which is save lives. We need to do it in a rational manner using proper triage tools that we will provide. in this series of webinars. And just remember that people with severe acute respiratory infection associated with COVID can progress to acute organ failure that requires ICU, meaning we cannot delay the ICU admission. And what I mean is next, once our patient is already admitted with a severe form of COVID-19, we cannot wait to be aggressive in the treatment and to do an early diagnosis of progression to actually admit them in ICU. Unfortunately, up to this day, the prognosis once our patients are in the ICU is not good. So we need to anticipate the treatment, especially with the oxygen supply. We need to use and we need to know the tools. Who are the suspected cases, the probable cases, and the confirmed cases? This is very simple. We just need to use these criteria in order to actually classify and administrate our resources, with the cases also referring to the severity of symptoms. And just remembering that at this moment where there is community transmission, we need to suspect that everybody with respiratory symptoms can be a COVID. So we do need to isolate them. That is first. We need to do the proper triage with prevention control measures. And of course, using our protective measures for healthcare workers. What we said about screening, it has to happen at every level. And here we see the ambulances. If we have a call and we do go to a house, we need to make the questions at the very first moment in order to assess that at that visit we will face with a person that is a suspected case. At that very moment, we need to put the preventing measures in place. And just remember that all patients should be screened with the case definitions. Either we use a WHO as international standard or the national standard. But the message I want to give is that we need to have a clear idea in our mind of what it is and what it is not in order to do proper utilization of the resources. So as we said, we need to do screening at first when we actually go and see our patients, and then do the special triage that is done in the hospital to assess the severity and the acuity to give the proper treatment in the hospital. Just remember, and we can see it down here, once we have a suspected case, we need to isolate that person, either home if the clinical features allow, or treat it in the hospital, okay? But let's not neglect the use of home isolation when the criteria applies. If the patient is not a suspected case, he can go through the normal pathway that we usually have. But let's remember, we do need to assess whether this person has been a contact of an active case, because in 40, if it has been exposed 24 or 48 hours earlier to a case, he or she can develop symptoms in 1 to 14 days later on. So please keep that in mind. It is very usual, and I am sure all of us have gone through that. We admit a patient who is not a suspected case, and suddenly 5 days before that patient develops respiratory symptoms, we do the test and it is COVID. So it is very important that we keep that in mind, because imagine the repercussions of those doctors and nurses or other patients in non-isolated areas that have been exposed to this kind of patients. I will go to next. So just to show you an example, and there is an Ukrainian version of this tool that is being distributed in the hospitals in Ukraine, and I will make it extensive to primary health care and emergency medical systems. This is the tool to actually, in Ukrainian, to actually do a determination of what kind of patients we have. If we follow the algorithm, this patient with these clinical features, and he does have a saturation less than 90%, as we have spoke several times, or a high respiratory rate, or presence of emergency signs, he will need to be admitted. If he doesn't, we need to assess the risk factors. If he has one or more, he will need to be isolated and monitored in the hospital. But let me remind you, if that person is not showing symptoms of moderate to severe disease, or according to our clinical criteria, however he has any risk factor, we have the proper knowledge to say that that person won't develop a severe disease, you can afford yourself to isolate that people home in order to save the beds in the hospital for the severe cases. I will go on. We have the same with pneumonia. Sometimes in the clinical community, we think that once we diagnose pneumonia, you can diagnose it with your chest X-ray, but you can do also a clinical diagnosis of pneumonia with the clinical features and your stethoscope. COVID can cause pneumonia. Pneumonia doesn't mean you always need to be admitted in the hospital. If we follow the algorithm, if we do not have risk factors, if we are not more than 60 years of age, we don't have hypertension, diabetes, or a cardiovascular disease, we can be isolated at a community facility or home. And just a brief comment about antimicrobials. We will use antimicrobials for community-acquired pathogens if suspected, meaning if we have, yes, a pneumonia, but we think it is just caused by COVID, we don't need to put a prophylactic course of antibiotics. We will just use the antibiotics when we have the suspicion of bacterial pneumonia associated to COVID. Of course, when it is a severe feature, we will use oxygen and isolation in a health facility. The severe pneumonia, these are a few features of severe pneumonia to actually identify in our clinic visits, okay? When it comes to adults or when it comes to children, respiratory breathing. I will share all this presentation, and as I said, I will share all the Ukrainian translated algorithms and tools for all our audience. So it is important that we are familiar with these criteria in order to actually rule in or rule out whether this patient is developing pneumonia or not. Okay. Let us also think that as we saw, we can have a patient with a pneumonia and we are thinking about doing home isolation or just a community-based isolation, not in the hospital. We need to look at the signs of progression or deterioration. If the patient is already dizzy, there is a decreased urine output. If breathing difficulties are increasing, if we can already see cyanosis, confusion, the fever persists more than 3 days without signs of resolution, we need to think that this pneumonia is not doing right. And then we need to take him to the hospital for proper care. Just a few notions about the oxygen therapy. We already know that it is what we have to put to every case of severe acute respiratory infection and respiratory distress to try to reach 94% of saturation of oxygens. We will start with 5 liters, 1 or 2 in children with a nasal cannula, and we have to monitor the saturation. We need to be very careful because the clinical signs of hypoxemia are unreliable, meaning this person may be doing good, may be saying, no, I don't have shortness of breath, I am feeling good, I'm not dizzy, but with our monitors, we could see the saturation of oxygen is low. We need to go on with the oxygen therapy. The clinical feature won't be over the monitoring feature. We need to have access to pulse oximeters so that we, at all the places where we are delivering oxygen, meaning if we do a home visit, we should have a pulse oximeter to actually know and give proper information later on to our colleagues in the hospital of the evolution of the oxygen during the visit and the transfer if it is done. Let's go to the next. Also, we need to think of the emergency signs. If the patient has an obstructed airway, if there is clear signs of severe respiratory distress or central cyanosis, we don't need to wait. We need to start our oxygen therapy right away. If there are signs of shock, of course, coma, seizures, or signs of severe dehydration. This is very important. Sometimes we go to see a patient and we think, okay, he is just dehydrated. The family cannot tell us the story of illness very, very good. At this time of community transmission of COVID, if we find severe dehydrated patients at home, we need to start the oxygen therapy. And how do we do it? This is all included in the tool translated into Ukrainian that you will all have access. We need to start gently with 5 liters with our nasal cannula. Okay, the patient need to be in a prone position, and then we need to see if the respiratory distress improves or not. If it doesn't, and the saturation is below 90, we need to change into the face mask and keep on monitoring. And then go on, we have to keep on increasing the supply of oxygen if it's not improving. And of course, we need to upgrade the mask that we are providing. If in the end, the patient doesn't respond to our oxygen therapy in an emergency basis, we need to evaluate whether that patient will need endotracheal intubation. We do have to start manual ventilation with the bag. I want to stress this fact that when we are doing our visits, we are doing our things properly, and we think that the patient is not improving because of their clinical features. But let's remember, we are doing a procedure. We are in a home. We are using our portable equipment. So we need to think about several things on this checklist that I am showing you. Is the measurement correct? Like, okay, this patient is not giving me a proper oxygen saturation figure, even though I am given proper oxygen supply. We need to do the measurement again. We need to change the pulse oximeter. And if we can, we will do arterial blood gas. That, of course, cannot be done at home with our resources. We need to think whether there is oxygen in the cylinder, whether it is full, whether the concentrator is on. I know it sounds obvious, but when we are home, when we are at the emergency room and we need to run, sometimes we are just looking at the patient. We need to give a step backwards and have a look at the big picture and look at all the supplies and the resources that we are using, okay? So these things are very important to check. Also, are we using the correct type of mask in this kind of patient? If we are using the reservoir bag, is it full? Or the tubing, is it kinked? Very important, okay? If the patient is not responding, is there another illness that is actually taking me to this situation? The patient has actually an acute respiratory distress symptom, or is he going through an acute heart failure or others, okay? So it is important that we actually look at all these aspects. When we actually think of taking our patient, because we have already decided that this is a severe case or this is a moderate case with risk factors, and we do want to admit him or her in the hospital, we need to think of these things at all times. Infection prevention and control measures in place. It is not possible that today in Ukraine, with a proper PPE supply, any of us actually makes a transfer of a patient without the proper PPE on place. Of course, the patient should always wear the mask. And as we said before, everything is secured. The airway, the tubes, the IV if we place, the monitor, and the tracheal tubes if the patient was intubated, the ventilators, We need to know before we actually do our visits that we do have vasopressors and sedatives in case we need to intubate our patients, because we may find this. And Ukraine is a very, very big country. Sometimes we need to do transfers of hours. So we need to be ready to respond when we actually get on our ambulance and go to make a visit, because we do not know what we are going to face. And remember, always enough oxygen from both our cylinders and trying to get the adequate oxygen saturation in our patients. If the patient is not responding, we will upgrade the supply with both the liters per minute and the type of mask that we are using. Also, if the patient is on shock or sepsis, we have to remember to bring our IV fluids and keep the proper blood pressure. And also, let's try to get our colleagues in the emergency room ready to receive our patient when we are doing our transfer. It's not that we are doing a 2 hours transfer and we don't call to the hospital to say that we are arriving. People in the hospital need to be ready, okay? In order to do proper admission, new analysis of the situation of the patient, and then admission. And when we want to do admission, what we have to look at is next. We have to have our blood cell count properly. We need to have our chemistry, our chest X-ray. We need to take samples in order to do our test, okay? Blood samples for culture if we are thinking that this patient may have a septic shock before the antimicrobials. If we have already given the antibiotics to the patient, this culture will probably be negative. It doesn't mean that he is not going through a septic shock, okay? The emergency treatments are given and the patient's response is checked. And what I mean is next. We have done our transfer with our patient. We get to the emergency room. Before deciding to what ward this patient is going, to the regular COVID ward or to intensive care, we need to make an analysis of the treatment that he's got and the response that he's given. Oxygen therapy, we have the proper IV, and we have put vasopressors if there is a shock. Just remember that the antibiotics will be given if we suspect bacterial pneumonia or we can actually objectivize it, okay? We need to complete our records. I need to know that when I go home, my colleague will know what I have done with my patients. So proper recording of our work. Just remember that it is very important to actually determine the level of care that the patient will need. ICU, high dependency unit, or the ward. Always the infection prevention and control measures that the patient needs in case of COVID are all that we have talked before. We have to have verbal communication with the staff completed to ensure continuity of care, meaning I am going to take you this patient. These are the characteristics. Are you ready to receive? That is very important because if we are not ready, we are exposing us, healthcare workers, to an infection when we can actually protect ourselves. So better to take quiet steps to inform to our colleagues when we are doing transfers in the health facility. And just a little algorithm to actually know and make a decision on what we should do with a patient if he has a severe display and we need to admit them on the ICU. We need to look at the severity of the clinical condition and the resource availability. And this is very important. We cannot push the system that much to say, I need ICU beds. Of course, we need them. Of course, I have critical patients, but we need to understand how our system in the community, in the oblast is, so I can do proper transfer and proper reception of patients because we have a limited number of ICU beds. So remember that where oxygen therapy is available only in the ICU, we will admit all the severe acute respiratory infections to the ICU, meaning the most severe cases will go to ICU, okay? If we have oxygen therapy throughout the hospital, we can actually distinguish between the more severe and the not that severe. And you can have a look here on your right of a scoring, okay, where you can actually consider on how to do an admission at the hospital, home base, or the ICU. This is an international standard approved by WHO. And this is the end of my presentation. This is just a summary of all that we can do technically wise when we actually treat our patients. I encourage you to enroll to the clinical management courses that will be held weekly by WHO. The presentations will be recorded, so you will have access to them whenever in time. But what I expect from all the medical community here in Ukraine is that we put our efforts together, and WHO is here for it, to actually unify and understand the guidance so that we can do a proper utilization of resources and take the best care of our fellow Ukrainians. So thank you very much. Дякую.
Thank you very much, Israel. Israel, do you hear us?
Yes.
Israel, do you hear us?
Yes, I do. Can you hear me?
Okay, that's probably me who is not hearing you. Just a sec. Just a second. I am trying to check whether there are questions to you.
Thank you.
So basically, the question is, Олег, я читаю на украинском, ты, наверное, переводишь. Так, сейчас, одну секундочку. Итак, в амбулатории...
Well, in the GP setting, so intensive care treatment is impossible to be managed. So in the guidance, only the pyrogenics, dexamethasone, so to the non-oxygen dependent patients cannot be administered at home. How do we manage these patients?
You say that you cannot manage patients at the primary health care. Okay, I totally understand. But in the primary health care, if these patients, they do not require oxygen and they do not have risk factors, they can have home-based isolation and monitoring and treatment. The thing we need to do is just to monitor every 24 to 48 hours to see the evolution of patients. If we work at the primary health care facility, we do know our population and we can afford, even if my patient has high blood pressure, diabetes, we can afford a certain range of safety to have him home and do monitoring on the phone. If the patient doesn't progress appropriately, they need to go to the hospital. In any case, when the saturation of oxygen is less than 90, this person needs oxygen supply. My understanding is at the primary health facilities, we cannot supply oxygen, so this patient needs hospital transfer.
Так, следующий вопрос.
Well, next up here, Irina Prunenko is asking, how do we manage hypothermia that is resistant to the conventional pyrogenics? So with the COVID-19 associated pneumonia patient, so we have good saturation per calcitonine 001 and without leukocyte formula.
Okay. You said you cannot control hyperthermia, right?
Да, при нормальной сатурации.
Yeah, the answer is yes, but the saturation is okay, normal one.
Okay, as we can see in the algorithm, if a patient goes 3 days beyond the fever that we cannot control, that patient needs to be evaluated again. And as we discussed before, The danger with COVID is that our patient may be 5 days, 6 days, okay, just going through flu-like symptoms, but the danger is that they can deteriorate very fast. So today we have no more than paracetamol to actually treat. If you suspect that this patient is already developing a pneumonia, bacterial pneumonia, because of the days that has been home and because of the leukocytosis formula. Usually in COVID, you will have leukopenia, you will have a descent in the number of leukocytes. But if you already find leukocytosis, like the number of white cells is high, and you have a deviation to the right, you have a lot of neutrophils, and you can see that the place in the chest where you suspect the pneumonia is clear according to clinical features. If you have access to chest X-ray, that is good as well. You should start with acquired pneumonia treatment. With that, you have at least 1 or 2 days with the antibiotic, the patient home. If he doesn't have a good progress, he will need to be admitted. Because as I said, what you don't want to find is a patient that finally will deteriorate and will need oxygen supply in a much higher level. So we need to have a close monitoring with our patients.
Спасибо, Израиль.
Okay, thank you, Israel. And actually then, so we are about to close out this conference, so in conjunction with Alexander Daniluk. So can you put us all together out on the screen?
Олег, спасибо за перевод, пока нас выводят на экран. Да, можешь отключаться, всегда приятно слушать твой голос. Да, спасибо. Наверное, как мы перейдем к завершению, я таких несколько скажу слов и выскажу несколько предложений. Да? Я вместо своей презентации, которую мы заявляли, лучше, наверное, скажу несколько слов, несколько таких предложений. Я не знаю, сколько нас людей еще слушает, сейчас, может быть, мне про это напишут на данный момент, но из того, что вижу я, у докторов, у фельдшеров, у диспетчеров, у водителей, у всех, кто работает на экстренке, есть масса пациентских вопросов в связи с той же самой вакцинацией от COVID. То есть масса всяких опасений, пациентских вопросов, связанных с сопутствующими заболеваниями, с тех, что люди считают в новостях и так далее. Мы предлагаем работать дальше с экстренкой, так как мы начали это делать с Киевской областью и с Черновецкой областью. Те, кто нас сейчас слушает, выдвигайте свои предложения. Мы готовы организовывать для вас зумы, причем запись этого зума вы можете потом отсматривать, когда вы приехали, например, с работы, даже если вы, например, не успели прямо в этот момент быть с нами в зуме. И мы готовы работать одновременно с несколькими регионами в рамках и вакцинации от ковида раз, во-вторых, вашего обмена опытом, поскольку мне кажется, что презентации из регионов очень важны, чтобы люди видели, как обстоят дела в разных регионах в экстренке сейчас, и со всеми вопросами качественного оказания помощи во время ковида. То есть я предлагаю такие, проводить штуки для нескольких регионов, например, одновременно, да, то есть мы обсудим с Александром, в каком дизайне, и как он захочет, и насколько это удобно, и как это должно происходить. Мы вам всем очень благодарны, что вы были в этой конференции сегодня. Вас было много, и вы сидели от начала до конца в большом количестве в Zoom и смотрели нас в YouTube и в Facebook. Смотрите, пожалуйста, на странице ЮНИСЕФ, на YouTube-канале ЮНИСЕФ и на YouTube-канале доктора Булавинова презентации, которые могут оказаться важными для вас про опыт других стран с вакцинацией от ковид, про опыт других стран в лечении ковида. И самые разные интервью, в том числе с Александром Данилюком, которое было сделано совсем недавно в больших подробностях про работу экстренки. Очень много у нас там есть эфиров с НСЗУ, и есть много эфиров с Федором Лапием. Те из вас, кто туда не заходил, заходите на эти каналы, нажимайте на кнопочку «Видео», и высыпятся там вам эти полезные эфиры. И на этом я передаю слово Александру Данилюку для закрытия этой конференции. Спасибо.
Дякую, Катерино, дякую, шановні колеги, система екстреної медичної допомоги, що ви з нами провели цей продуктивний день, майже Більше ніж півдня ми разом провели. Сподіваюся, що вам була корисна вся інформація, яку ви почули. На ті питання, які не встигли відповісти, ми їх розішлемо після опрацювання. І думаю, що ми і спільно з ЮНІСЕФом, з ВООЗом і іншими організаціями будемо продовжувати вас тримати на пульсі подій. Дякую, що ми прожили 2020 рік. Дякую, що ви тримаєте нашу екстрену медичну допомогу. Дякуємо, що даєте нам надію і віру в те, що до кожного при потребі приїде професійна бригада. Ми віримо в вас, і ми дякуємо вам за вашу щоденну роботу на передовій екстреної медичної допомоги. І бажаю вам розвитку, бажаю вам бути здоровими, вакцинуйтеся, тримайте дистанцію, не забувайте про засоби індивідуального захисту. І бажаю вам успіхів щодня, як у роботі, так і у житті. Команда МОЗ, команда Екстренки МОЗ завжди з вами. Тому до нових зустрічей. Працюємо. До побачення. Дякую.